We will move now on to the last paper, and it's entitled Apheresis in COVID-19, so clearly a very timely topic, and will be presented by a longtime colleague, Dr. Kiprov from San Francisco. Dr. Kiprov.
Thank you, Gail. Thank you for inviting me to this exciting conference. The only regret I have is that we're virtual. I wished we were some nice place in Canada, and so next time we'll do that. In the meantime, I will discuss the reason why we're not together. It wouldn't be an exaggeration to say that COVID-19 has caused massive confusion and uncertainty throughout the world. This disease is caused by a novel coronavirus called SARS-CoV-2, and first case was reported from China, from Wuhan, China, in December of 2019. Since then, a lot of months have passed, and over the last 8 months, this virus has been responsible for over 1 million deaths throughout the world. The virus enters the human body through an ACE2 receptor, which is present on the membrane of just about any cell in the human body. So this virus has access to any organ of the body. It penetrates through the nasopharynx, infects the nasopharynx, and then it moves towards the lungs, and from there it goes all over, and no organ is being spared. The clinical features can vary. Some people get a very mild disease, similar to the seasonal cold, and usually recover without any problem. Others have a moderate disease, similar to the seasonal flu, and others have a severe respiratory insufficiency, renal insufficiency, cytokine storm, which we will discuss in a minute. And this group is usually not doing well. Either they die, or if they don't die, they have permanent organ damage, either in the lungs, the kidneys, or the nervous system. It is interesting to note that 93% of the deaths occur in patients who are over 50 years old. So older individuals are particularly vulnerable to this disease. Other risk factors are obesity, underlying conditions, and obviously race and socioeconomic status. But in all these situations, except for the last one, chronic inflammation seems to play an important role. And an editorial in New England Journal of Medicine, early after discovering these risk factors, stated that immunity in aging population is an area that we should research very carefully in the future. Now, how do we approach a pandemic? We approached it with a 13th century style lockdown. So hide at home and don't get exposed, and that's what people for many centuries have done. The other thing, a little more modern but still pretty old, is convalescent plasma. We have used convalescent plasma in the last 20 years for a variety of viruses. Ebola comes to mind. In the United States, convalescent plasma became a big deal. There were two large studies, one from Mount Sinai in New York, and the other a combination between the Mayo Clinic and Johns Hopkins. Both studies reported large cases, and they were controlled, but they got a lot of criticism because there was no placebo in neither of those. In general, I'm not going to take you through the details. In general, what both studies found, that if the plasma is used early in the disease, it is successful, and it becomes less successful if you use it later in more difficult stages of the disease. After the convalescent plasma will be the development of a vaccine. Initially, there was a great deal of skepticism that vaccine can be developed rapidly, and the reason for that is because of our previous experience with vaccines. It took Bill Gates more than $1 billion and 30 years to develop a questionable malaria vaccine, and we have spent even more money and more scientific effort trying to develop an HIV vaccine, and we still don't have it. So the skepticism was there. However, interestingly enough, and for the better of the world, a vaccine was developed, and is effective, and it will be most likely distributed by the end of next month. This is a historic moment for science, medicine, and biopharma. Let us take a look at how the immune system responds to a viral infection, including the new coronavirus. The first response is acute inflammation. As the inflammation progresses, hundreds of inflammatory cytokines and chemokines are released in the circulation. Once the virus is killed, regulatory factors intervene and bring down the immune system to its dormant state. In some medical conditions, as well as in older people, the regulatory system of the immune system does not function properly, and that results in chronic inflammation. As you can see here on the red curve, the acute immune response does not go back to its dormant state, but rather continues the inflammatory response, albeit not as intense as the one during acute inflammation. Chronic inflammation is less intense, but persistent and relentless. Chronic inflammation is characterized by continuous presence of pro-inflammatory cytokines in the circulation. So this is what happens if somebody has chronic inflammation. There are already a bunch of cytokines that circulate in the blood. And if this person gets infected with coronavirus, this triggers acute inflammation. As we saw before, acute inflammation is characterized by the production of hundreds of new cytokines and chemokines. So the system gets overwhelmed and induces something that we call cytokine storm. Now, cytokine storm is not unique to COVID-19. As we heard earlier today, it can occur in sepsis. I can tell you that it occurs in patients who receive CAR T cell infusions. The pathophysiology of the cytokine storm in these different situations is different. We're not going to go into this, but what I just described is what happens in COVID-19. The tissue damage in the severe form of COVID-19 is overwhelming. The organs are attacked both by the virus as well as by the cytokine storm. Although some of these patients do survive, the organ damage is irreversible, and that has, of course, clinical consequences. So how do we deal with treatment and prevention of COVID-19? Obviously, we have to attack the virus, we have to treat the cytokine storm, or maybe prevent it from happening. And obviously, we have to address the issue with chronic inflammation. Now, attacking the virus, we already have done that. Fortunately for all of us, a vaccine is available, and there are 5 or 6 more that are on the way and will be available early next year. We have remdesivir, which is an antiviral medication. It's not perfect, but if given early in the disease, it works. We have convalescent plasma, and from this convalescent plasma, we can develop IVIG that is specific for COVID-19. And as you know, there are monoclonal antibodies that are being developed, and actually one was approved by the FDA either this or last week, and this is the antibodies that President Trump was treated with. Another interesting approach to treat COVID-19 is using CAR T and other engineered immune cells, such as NK cells. Currently, there are a couple ongoing clinical trials. Now, how do we address the cytokine storm? Big Pharma jumped right away into this and decided to use monoclonal antibodies to IL-6. It is impossible to think that a single monoclonal antibody against one cytokine will fight a cytokine storm of hundreds of cytokines. So this is really not the answer. Some people have addressed the issue by selective removal of cytokines with different columns. On the bottom here you see the cytosorb. It is not an apheresis column. It works with CRRT or ECMO. And on top here we see the Terumo Optia machine, which is coupled with a cartridge developed by Marker Therapeutics, which is a German company. So this may have some relevance. Unfortunately, none of these have yielded any results for me to report. I don't know. I think that they're in clinical trials, but there has been no information of their accomplishments or failures. And then, of course, there is the old-fashioned conventional plasmapheresis. Early in the pandemic, it was postulated that therapeutic plasma exchange may be helpful in this disease. And this was based on what we already heard this morning, is the fact that plasmapheresis has been somewhat successfully used in sepsis, where the cytokine storm has been treated, as we mentioned, successfully with plasma exchange. There are reports also for plasma exchange as an alternative modality for severe cytokine storm in patients receiving CAR T infusions. This has been successful as well. Later in the pandemic, a number of case reports started popping up of using plasma exchange and other blood purification therapy for reducing the cytokine storm. I chose this particular one. I'm not going to show you all of them, but this particular one actually used plasma exchange, just conventional plasma exchange. And here you can see the reduction of C-reactive protein IL-6, cytokines pro-inflammatory, and an increase in lymphocytes. A characteristic feature of this disease is lymphopenia. There are two controlled clinical trials that have been reported, and they do not have placebo, but they have a control group that did not receive plasma exchange. And they both show similar results, which I kind of put together here. As you can see on the left-hand side at the bottom with red, to a 28-day survival was 91% in the TPE group and 61% in the control group. Hospital stay was 5 days shorter in the TPE group, and the resolution of the cytokine storm is 6 days, which is half of what the control group was. So these results, again, without the placebo and with a limited number, are encouraging, but not definitive, obviously. Now, early in I think it was March, I got a phone call about a patient with Guillain-Barré syndrome who happened to be COVID-19 positive, but really didn't have the disease. And they asked me, have you seen this? And I said no. And this patient was treated the way we treat Guillain-Barré syndrome, with plasma exchange without IVIG, and did well. Since then, there have been a number of patients and case reports from all over the world. Fortunately, the majority of these patients, as you can see here at the bottom, 62% do well, either with IVIG and/or plasmapheresis. Now, some of these patients will have the full-blown COVID-19 disease, and some will not. Some will have just the neurologic problem. Other neurologic autoimmune problems include meningoencephalitis, and again, there has been a small series of improvement after TPE. And a disease that may become somewhat interesting in this whole pandemic and vaccination situation, it's called acute transverse myelitis. We heard about it a little bit today. It is category 2 in the ASVA indications book. What is really a problem, maybe, is that a COVID-19 vaccine may precipitate this particular disease. So we may be seeing more of that. I hope not, but it's a possibility. Another thing that we heard today also is coagulopathy with antiphospholipid antibodies. We know how to treat that. We have published already on a 15-year of our experience. I think we do very well with treating this disease. The lessons that we have learned so far is that everything that we do should be done really very early. Remdesivir works if it's given early. Convalescent plasma works if it's given early. The antibodies work if it's given early. Plasmapheresis and cytokine removal devices work if given early in our experience. If you wait too long, if you wait till the cytokine storm really takes place and overwhelms the system, you're not going to succeed. So I'm going to talk to you for a couple of minutes about prevention in this disease, where I do believe that this is the answer. We should not allow it to get to a point of treatment. We should try to prevent this disease. So one way to do that is obviously active immunity with vaccines. The problem we're facing is that older people respond poorly to vaccines. This has been proven time and time again. So we have in our disposal passive immunity with convalescent plasma and intravenous immunoglobulin, either regular immunoglobulin or the ones that are coming with specificity for COVID-19. So here is a study that was done with intravenous immunoglobulin, conventional one, in the pandemic of H1N1, and it was very successful. Recently I found an article of treatment with plasma exchange followed by conventional IVIG in a critically ill patient with COVID-19. Early in the pandemic, we published in Transfusion and Apheresis Science that we believe the TPE with a combination of 5% albumin and convalescent plasma replacement at the end of the procedure can be a valuable treatment option for COVID-19 patients and warrants a comparison trial with simple convalescent plasma infusion. Such a trial is ongoing now in Scandinavia, and we're eagerly awaiting the results of this study. In a more recent publication, we were able to demonstrate that TPE has a rejuvenative effect on many tissues and also has an anti-inflammatory effect, which reduces the consequences of chronic inflammation. I think that this is very encouraging and leads me to make a speculation that therapeutic plasma exchange can upregulate the immune system in older people, have an overall rejuvenation effect, and if this is followed with IVIG, with or without specific antibodies, this may be an approach to prevent the disease in older people. Thank you very much.